Assalamualaikum and good day. Today we are going to look into pathology of the parathyroid gland. First we look at the normal histology of the parathyroid gland. It consists of two types of cells, the principal or chief cells that secretes the parathyroid hormone, and the oxyphil cells, the function of which is still unknown. The parathyroid hormone is controlled by the concentration of free calcium in the blood. Low levels of serum calcium stimulates the release of the parathyroid hormone, which will restore the calcium to its normal level. The parathyroid hormone promotes bone resorption by osteoclasts, promotes active reabsorption of calcium from the kidney, and also enhances the absorption of calcium in the intestine. All this will increase the calcium level. It also reduces the phosphate level by reducing the uptake of phosphate from the kidney, thus the kidney loses the phosphate. There are two pathological conditions that can be seen in the parathyroid gland. First is hyperparathyroidism, which is excess of parathyroid hormone secretion and thus causes hypercalcemia. Another is hypoparathyroidism, which is reduced parathyroid hormone secretion and thus this causes hypocalcemia. First, we look at hyperparathyroidism. It is classified into three: primary, secondary, and tertiary. Primary hyperparathyroidism is caused by autonomous spontaneous overproduction of parathyroid hormone. We will look at the causes later. Secondary and tertiary hyperparathyroidism are conditions related mainly to chronic renal failure. The causes of primary hyperparathyroidism includes adenoma, which is the most common cause, primary hyperplasia, and parathyroid carcinoma, which is the least common cause. Women are more affected than men in primary hyperparathyroidism, and it often affects the elderly. More than 95% of the cases are sporadic cases, which occur spontaneously. A few are caused by genetic syndromes such as multiple endocrine neoplasia 1, MEN2, and familial hypocalciuric hypercalcemia. Parathyroid adenoma is almost always solitary. Preoperative scintigraphy is used to localize and distinguish adenomas from parathyroid hyperplasia. Adenomas usually affects one gland, whereas hyperplasia usually affects more than one gland. Grossly, the parathyroid adenoma is similar to the normal gland, but it's larger in size, is well circumscribed and encapsulated, and there is a rim of non-neoplastic parathyroid tissue present at the edge, such as here. Under high power, you can see the parathyroid adenoma is composed of fairly uniform cells with small nuclei. Rare pleomorphisms are seen and mitotic figures are rarely seen. Two molecular defects are seen in sporadic parathyroid adenomas. The first one is overexpression of cyclin D1, which causes the cells to proliferate. The second one is MEN1 mutation, a tumor suppressor gene. The genetic syndromes associated with familial parathyroid adenomas include multiple endocrine neoplasia type 1 and type 2, and familial hypocalciuric hypercalcemia. This is a rare autosomal dominant disorder caused by loss of function mutations in the parathyroid calcium sensing receptor gene, which results in decreased sensitivity to extracellular calcium. The next cause of primary hyperparathyroidism is parathyroid hyperplasia. It may occur sporadically or as a component of MEN syndrome. Classically, all 4 glands are involved. Compare this to parathyroid adenoma. The combined weight of all the 4 glands are less than 1 gram. Microscopically, the usual hyperplasia that is seen is chief cell hyperplasia, and the hyperplasia may be diffuse or multinodular in pattern. The least common cause of primary hyperparathyroidism is parathyroid carcinoma. It may be a circumscribed lesion or a clearly invasive neoplasm. The cells are usually uniform and resemble normal parathyroid gland tissue. Local recurrence occurs in 1/3 of cases, and more distant dissemination occurs in another third. Grossly, it is a solitary gland with irregular margin and grayish-brown in color. It may exceed 10 grams in weight. The diagnosis of carcinoma based on cytologic detail is unreliable. The cells may look benign, but the only reliable criteria for malignancy are invasion of the surrounding tissue and metastasis to distant organ. Primary hyperparathyroidism may present as asymptomatic and only identified on routine blood chemistry profile, or it may present as associated with classical clinical manifestation of primary hyperparathyroidism. Because serum calcium levels are routinely assessed, most patients with primary hyperparathyroidism are diagnosed incidentally on the basis of clinically silent hypercalcemia. Primary hyperparathyroidism is the most common cause of asymptomatic hypercalcemia. Other causes of hypercalcemia are listed below. Most importantly is hypercalcemia of malignancy, where malignant cells causes either parathyroid hormone-related protein secretion or osteolytic metastasis. Another cause is vitamin D toxicity or hypervitaminosis D, granulomatous diseases such as sarcoidosis, which cause elevated vitamin D levels, thiazide diuretics, which decrease the renal calcium excretion, immobilization, which increase bone resorption, and familial hypocalciuric hypercalcemia. Hyperparathyroidism can affect the bone, the kidney, the GI tract, and the central nervous system. In the bones, it causes dissecting osteitis, osteoporosis, osteitis fibrosa cystica, and brown tumors. In the kidney, it can cause renal stones and renal tissue calcification. In the GI tract, it can cause peptic ulcer or pancreatitis. And the central nervous system, it causes lethargy, weakness, confusion, and coma. It is classically presented as painful bones, renal stones, abdominal groans, and psychic moans. In hyperparathyroidism, the excess parathyroid hormone causes increased number of active osteoclasts, and the osteoclast can tunnel and dissect into the center of the bone, just like in the picture. So this is called dissecting osteitis. In hyperparathyroidism, there is excessive bone resorption due to the osteoclast activation, and this leads to osteoporosis. Another manifestation of hyperparathyroidism is osteitis fibrosa cystica, where there is numerous active osteoclasts and increased bone resorption with replacement of the bone with fibrous tissue. This is due to the increased parathyroid hormone. In severe hyperparathyroidism, there can be an expansile tumor composed of proliferation of osteoclasts, hemorrhage, and hemosiderin. This is called brown tumor. Under normal conditions, parathyroid hormone causes the kidney to limit calcium excretion. But with the overwhelming serum calcium produced with hyperparathyroidism, the kidney are forced to excrete the extra calcium into the urine, causing hypercalciuria. The excretion of high level of calcium or hypercalciuria favors supersaturation. This is a condition whereby there is an increased concentration of calcium exceeding its solubility. So this will cause stone formation and deposition of calcium in the renal tissue. Urinary tract stones is called nephrolithiasis, and calcification of renal interstitium is called nephrocalcinosis. Excess calcium can stimulate gastrin production in the stomach. So the gastrin production causes increased acid secretion, and this hyperacidity predisposed to peptic ulcer disease as seen in the picture. Hypercalcemia is also associated with acute and chronic pancreatitis. The metastatic calcification due to the excess calcium can cause pancreatic duct obstruction, which can precipitate pancreatitis. Calcium can also activate enzymes, and one of the enzymes that is activated is trypsinogen, which can self-digest the pancreas. With mild hypercalcemia, patients begin to feel fatigued. High levels of hypercalcemia may cause anxiety, depression, personality changes, and confusion. With very high levels, somnolence, coma, and death may ensue. The CNS effects are thought to be due to direct depressant effect of hypercalcemia. Hypercalcemia can cause metastatic calcification in various sites, such as the stomach, the lungs, myocardium, and the valves, and blood vessels. You can see in this picture metastatic calcification in the valves, such as seen here. Secondary hyperparathyroidism are conditions associated with chronic depression of the serum calcium level. The low calcium level will stimulate parathyroid gland to produce parathyroid hormone. The most common cause of secondary hyperparathyroidism is renal failure, followed by inadequate calcium intake, vitamin D deficiency, and steatorrhea. Chronic renal failure causes decreased phosphate excretion, which results in hyperphosphatemia. The raised serum phosphate levels depress the serum calcium levels because hyperphosphatemia complexes with serum calcium, leading to lower than normal levels of calcium. The lower level of calcium stimulate parathyroid gland activity, causing hyperparathyroidism. Chronic renal failure also reduces the alpha-1 hydroxylase to synthesize active vitamin D, thus reducing intestinal absorption of calcium, causing hypocalcemia, and thus increasing the parathyroid gland activity. What we see in secondary hyperparathyroidism is parathyroid hyperplasia. It may involve all four of the parathyroid glands. The bone changes that can be seen in secondary hyperparathyroidism are similar to the primary hyperparathyroidism. Metastatic calcification can also be seen to blood vessels, the lung, the heart, and the stomach. Secondary hyperparathyroidism is usually not as severe as primary hyperparathyroidism. The skeletal abnormalities tend to be milder, and control of the hyperparathyroidism allows the bony changes to go back to normal or disappear completely. The vascular calcification may cause ischemic changes to the skin and other organs, and patients often respond to vitamin D supplements and phosphate binders. Some patients with secondary hyperparathyroidism may develop tertiary hyperparathyroidism. After a prolonged period of secondary hyperparathyroidism, the parathyroid gland can autonomously produce parathyroid hormone excessively, and this causes hypercalcemia. Now we move to hypoparathyroidism. This is a far less common condition than hyperparathyroidism. Hypoparathyroidism causes hypocalcemia, and the main causes include surgically induced hypoparathyroidism, autoimmune, autosomal dominant, familial isolated hypoparathyroidism, and congenital absence of parathyroid glands. We go through the causes of hypoparathyroidism. Surgically induced hypoparathyroidism is usually due to accidental removal of all the parathyroid glands during thyroidectomy. Autoimmune hypoparathyroidism is caused by mutation in the autoimmune regulator gene and is associated with chronic mucocutaneous candidiasis and primary adrenal insufficiency. Autosomal dominant hypoparathyroidism, on the other hand, is caused by gain-of-function mutation in the CASR gene, and this results in hypocalcemia and hypercalciuria. Familial isolated hypoparathyroidism is a rare condition that can be caused by an autosomal dominant condition or an autosomal recessive condition. Congenital absence of parathyroid glands occur with other malformations such as thymic aplasia and cardiovascular defects. When thymic defects are present, the condition is called DiGeorge syndrome. It can also be caused by a component of 22q11 deletion syndrome. There are many clinical manifestations of hypocalcemia. The first one is tetany, which is involuntary contraction of muscles. This is caused by increased neuromuscular irritability and can be demonstrated by Schwostek or Trousseau sign. Dental abnormalities can occur when hypocalcemia is present during early development. Examples of dental abnormalities are dental hypoplasia, failure of teeth to erupt, defective enamel and root formation, and abraded carious teeth. Cardiovascular manifestation can be seen as conduction defect, such as prolonged QT wave. Mental status change can be seen as anxiety, depression, and emotional instability. Some intracranial manifestation, such as calcification of the basal ganglia, Parkinsonian-like movement disorders, increased intracranial pressure with resultant papilla edema can also be seen. Some eye disease, such as calcification of lens and cataract formation, can also be seen. Lastly, we look at pseudo-hypoparathyroidism. This is a hypoparathyroidism that is due to end organ resistance to the actions of parathyroid hormone. The serum parathyroid hormone levels are normal or even elevated at some times. This results from genetic defects in G protein-coupled receptors pathway, so the end organs are resistant to the actions of parathyroid hormone. This presents as hypocalcemia, hyperphosphatemia, and elevated circulating parathyroid hormone.